So when we talk about aortic stenosis, the severity is something that we are concerned about. You know, we're really concerned about the severity of the aortic stenosis, and everything we do is geared towards aortic stenosis severity. So you know, it's important to determine the severity of the aortic stenosis. This is just a guide, okay? So when we talk about severe aortic stenosis, we look at the peak velocity, and if it's greater than or equal to 4 meters per second, if the mean gradient is greater than or equal to 40 millimeters mercury, if the valve area is less than 1 centimeter squared, then this points to severe aortic stenosis. And in the absence of increased flow across the valve, then this is severe aortic stenosis. So all you have to do now is to correlate symptoms and signs with these numbers, and then you come up with, you know, is this real severe aortic stenosis? For patients who have a small, you know, for small individuals, you can index the valve area. So we just divide the valve area by the body surface area, and if it's less than 0.6, then it's usually severe. And then we talk about the dimensionless index. You can do it with the VTI. You can also do it with the velocity. So anything less than 0.25 is severe. So, you know, this is straightforward. But, you know, things in life are not straightforward a lot of the time. You know, we do have a low flow situation. So some patients with low volume flow across valve, they cannot generate that velocity, and hence they cannot generate that gradient, that pressure gradient. Remember, velocity is related to gradient because the gradient is equal to 4v squared from the simple Bernoulli equation. So if you have low flow across the valve, it stands that you will have low velocity and low gradient. We use the stroke volume index. That is a good measure of the flow across the valve. Remember, stroke volume is the volume of blood that's pumped out from the ventricle with each beat. So that's the volume that's pumped out from the ventricle with each beat. But we index it. So you just take the volume and you divide it by the body surface area to index it. And if you have a stroke volume index less than 35 mLs per meter squared, then this is suggesting that it is low. The blood flow across the valve, or the blood flow that's coming out of the ventricle, is low. So stroke volume index less than 35 mLs per meter squared suggests that you have a low flow situation. So if the aortic stenosis and you have evidence of a low flow, looking at the stroke volume index, and the velocity and gradient is not very high, then you have to do something more. You have to do more because, you know, you cannot just say that the patient have severe aortic stenosis. So if you have a low flow situation, you have to do more. And we're going to look and see what else you need to do. Again, only if we have you know, small individuals or very large individual, you're going to use the index. So for regular patients, the index is not necessary, but for very small and very large patients, yes. if okay, so let's sort of rationalize this, because there are things that can affect the velocity. There are things that can affect the stroke volume, and there are things that can affect the gradient. So I mean, the velocity is related to gradient. So if there's something that's going to affect the velocity, it's going to affect the gradient. Remember, hypertension, if someone has significant hypertension, blood pressure 220 over 120, that is pressure that the blood flow has to overcome. And as a result of that, the flow across the valve can be reduced. The velocity of flow across the aortic valve can be reduced, and hence the gradient. So whenever you doing these assessment of the aortic valve, you should get the blood pressure, and you should make sure the blood pressure is controlled. If it's not, then you're supposed to control the blood pressure, bring the patient back, and then do the study. So in the echo lab, we see a lot of patients who come in, and we get in numbers. I mean, there's a discrepancy between the continuity equation and the velocity and the gradient. There's a discordant in the measurements, and you have to sort that out. You can't just not sort it out. Okay, you have to figure out what's going on. So if we have a situation where, say, the valve area is greater than or equal to 1 centimeter squared, and if you have the velocity greater than or equal to, say, 4 meters per second, and the mean gradient is high, in the presence of a high transvalvular flow, you have to figure out what's going on, because looking at this valve area by the equation is not severe. Remember, severe is less than 1. So this situation is telling you that you don't have a severely stenotic aortic valve, but you have a high velocity and a high gradient. So this might just be a high flow situation, a high flow across the valve. And there are things that can give rise to that. So if you have a situation like this, you have to analyze what is going on here. There are a number of things that can give you a high flow across the valve. Significant aortic regurgitation, because blood is going back across the aortic valve into the left ventricle, and that same blood that goes back into the left ventricle is now going to go forward. So it's going to falsely increase the flow, the velocity, and the gradient across the valve. So if you have significant aortic regurgitation, you may get a falsely elevated velocity and a mean gradient. So be aware of that situation. If the patient have a shunt, arteriovenous shunt, you can get increased blood flow across the valve. And one of the common shunts that patients will have is a hemodialysis graft. So if the patient have a hemodialysis graft, you have to be aware of that. That can give you an increased flow, increased blood flow, and hence an increased velocity and an increased gradient. If the patient is severely anemic, that can also give rise to an increased blood flow. Hyperthyroidism, okay? A patient have a fever. So when you have discordant numbers, you have to analyze what is going on. So don't just put down the numbers and walk away. Is the patient blood pressure tremendously high, which gonna reduce the transvalvular gradient? Is the gradient very, very high in the valve area? is not severely stenotic. Patients have fever, anemia, uh, significant aortic insufficiency, hyperthyroidism, uh, atrioventricular fistula. So try and analyze the situation and see what's going on. However, the most challenging, the most vexing problem though is when you do your continuity equation and you get a severe, the number comes out showing that the patient has severe aortic stenosis, the valve area less than 1 centimeter squared, but the velocity is not more than 4 meters per second. The mean gradient is less than 40 millimeters mercury. So we see a lot of these situations, and you have to analyze what's going on here. You can't just write the numbers down and walk away. The first thing you have to do is check and see, did I make an error in my measurements? Remember, you measure the LVOT diameter and you square it. If you falsely or incorrectly get a smaller LVOT diameter than the patient really have, then that can give rise to the continuity equation giving you a valve area less than 1 centimeter squared. So look at your measurements, see if there's any error in your measurements. And then, of course, you're going to look at the different trans-aortic velocity. You're going to look at the LVOT velocity, the aortic valve velocity. Make sure that they were done properly, okay? And again, multiple windows. Because if you just use a window where the angle theta, which is the angle that the ultrasound beam makes with the moving blood, if that angle is significant because of where you're taking your sample, then you're going to get a gradient, a velocity and a gradient that is not significant. So you have to, when you do your studies, do your study from multiple windows, okay? All right, so the first thing you have to do is, double check that your measurements are accurate. If your measurements are accurate, okay, if your measurements are accurate, then there are a couple situations that you have to look at. So after exclusion of these reasons for discordant valve area and gradient, then you're going to consider low flow, low gradient AF. Yes. Okay. We have two situations with low flow, low gradient AS. You can have low flow, low gradient AS with reduced ejection fraction, and you can also have a low flow, low gradient AS with normal ejection fraction. Okay. So again, when you get a discordant figure, that is the valve area is coming out severe with the continuity equation, but the velocity, transvalvular velocity, and the gradient is not supporting severity. You may be dealing with a low flow, low gradient AS with reduced ejection fraction. There are some patients with an ejection fraction of 20–30%, and the heart muscle is weak and cannot generate significant flow across the valve. Okay? Again, if the ejection fraction is such that you cannot generate a significant flow across the valve to get a reasonable velocity and gradient, that may be one of the situations that you're dealing with. So and it's very important to analyze these patients carefully. because you can have a number of situations. You can have, say, you may have a patient who have had multiple heart attacks, multiple blockages, and the heart muscle is weak from that situation. Yeah, it's still not gonna generate significant flow across the valve, and you're gonna, have to do something to increase the flow across the valve to show that there is more concordance than discordance. However, when you have significant aortic stenosis over a period of time, that in itself can weaken the heart muscle. So you may be dealing with, either of these conditions. Patient having significant aortic stenosis, and as a result of that, they have reduced ejection fraction. So you have to be aware of this situation, and you have to try and tease it out and see what is going on here. However, the important thing is, if the continuity equation is showing you that the aortic valve area is less than 1 centimeter squared, but the velocity and the gradient is not supporting that, and the patient have a reduced ejection fraction, then this is a distinct entity. And the definition for this, there's a definition for it: low flow, low gradient AS with reduced ejection fraction. Okay, that is when we do the continuity equation and we look at the aortic valve area, it's less than 1 centimeter squared. That in itself is telling us that the aortic stenosis is severe. But when you look at the mean transvalvular, the mean aortic transvalvular gradient is less than 40. Remember the table that we look at said that the mean gradient should be greater than 40 for severe AS. If the ejection fraction is less than 50%, and if you do the stroke volume index and it's less than 35 mLs per meter squared, then this is the definition for low flow, low gradient AS with reduced ejection fraction. Again, low flow, low gradient AS with reduced ejection fraction. This is the diagnosis. Small area, not so significant transvalvular pressure gradient, ejection fraction is less than 50%, and the stroke volume, which tells you the amount of blood that's flowing across the aortic valve, is reduced. So when we have patients with low flow, low gradient AS, we have to do something we have to do an additional test. So ejection fraction 20%, valve area 0.9 centimeters squared, the velocity 3 meters per second, the mean gradient 35 or say 30 millimeters mercury. You have to do something in addition to just doing your data measurement, because some patients with an ejection fraction of 20%, because the heart muscle is so weak, they cannot open. The pressure generated in the ventricle cannot open the aortic valve. So when you do your calculation, you may get a valve area less than 1 centimeter squared. But if you were to increase the contractility of the heart muscle and now open the valve area, open the valve, when you do your calculation, you're going to see that the valve area is more than 1 centimeter squared. So when you have those patients with severe AS, but you have a low flow, low gradient situation, you have to do what we call a abutment stress echocardiography. Okay? And this is an exam question. People doing exam, they're going to, give you the scenario, and you'll diagnose low flow, low gradient AS, and they'll say, what tests are you going to do to confirm that the patient have significant aortic stenosis. So it's a abutment stress echo. So the abutment stress echo provides information on changes in the aortic velocity, the mean gradient, and the valve area as the flow increases. So you're gonna give the abutment. Remember, the abutment increases the contractility of the heart, and it's supposed to increase the flow across the valve. And if it increases the flow across the valve, then it's supposed to increase the stroke volume. It's supposed to increase the velocity, and it's supposed to increase the gradient. So that's the rationale behind using the abutment stress echo. And so severe aortic stenosis because you can have through severe aortic stenosis over time, giving rise to LV systolic dysfunction. And these patients are crying out to replace my valve, because once you replace the valve, the ejection fraction can normalize. Okay. All right. So I would say the trans aortic velocity is flow dependent. You increase the flow, then you're going to increase the velocity and the gradient. Okay. So what you want to do when you do your abutment stress test, you want to distinguish true aortic stenosis from pseudo severe aortic stenosis. Pseudo severe aortic stenosis, those patients don't have severe aortic stenosis, but because the heart muscle is weak and it cannot generate sufficient pressure and force to open the valve, then when you do your calculation, it's going to come out severe. But it's just because the heart muscle is weak and it can't open the valve. So you want to distinguish those two patients, because the patients who have pseudo severe aortic stenosis, they don't do very well if you take them to surgery. So it's very important that you distinguish the two groups, because patients with pseudo severe aortic stenosis don't do well if you take them to surgery. So you don't want to take a patient like that to surgery and there's no benefit. Remember, the surgery carry risk. Surgery carries some certain amount of risk. Okay, so in this situation, the aortic valve replacement may not lead to significant improvement in LV systolic function. Okay, and this patient doesn't do well. So when we do our abutment stress test, what is the aim? What is the goal? What are we trying to achieve? This is how you do the abutment stress test. Okay, so you're going to start your abutment about 2.5 to 5 micrograms per kilogram per minute. When we do regular abutment stress tests, we start about 5 or 10 mics, but remember, these are patients who possible have severe aortic stenosis. So if you start with higher dose abutment, you can cause arrhythmia, and some of these patients can succumb. So be careful. So that's why we start low, 2.5 to 5 micrograms per kilogram per minute, and you're going to increase the dose to you're going to increase the dose 2.5 to 5 micrograms per minute every 3 to 5 minutes. So every 3 to 5 minutes, you're going to increase by this amount, 2.5 to 5 micrograms per kilogram per minute. The maximum dose of the abutment you want to give is 20 micrograms per kilogram per minute. When we do a regular abutment stress test, we go as high as 40 micrograms per kilogram per minute. For the abutment stress test protocol for low flow, low gradient AS, the maximum is 20. How do you know you reach your target? So these are the things that we look at to determine if our target is met. So again, if the maximum dose of the abutment is 20, that you can't give anymore, so the protocol is finished. So if you reach the maximum of 20 micrograms per kilogram per minute, then the study is finished. Again, remember, you're starting at 2.5 to 5, and every 3 to 5 minutes, you're going to increase. So if a positive result is obtained, and I'm going to show you what the positive results are, okay? If the patient's heart rate increase 10 to 20 beats per minute above the baseline, or if the patient's heart rate exceeds 100, then this is also a reason to stop the study. If the patient develops symptoms, so the blood pressure fall, the patient develop any significant arrhythmia, then you need to stop. Okay? So if the maximum dose of dobutamine is reached, if the heart rate increased 10 to 20 beats above the baseline or is more than 100, if the patient has symptoms, and then if we get positive results. So what are we talking about when we say positive results? So this is what we're talking about. So remember, the aim is to distinguish true aortic stenosis from pseudo aortic stenosis. Those situations where because the heart muscle is weak, it couldn't open the valve. But when you increase the contractility, it opens the valve. And those patients don't have severe AS. So a positive result, if when you give your dobutamine and you do your continuity equation calculation of aortic valve area, it's now greater than 1 centimeter squared, then it's not severe. It is probably because the heart muscle was weak and couldn't open the valve. So, once you get this, then the patient don't have severe aortic stenosis, or, that answers the question. Another positive result is if when you give the dobutamine and you do your Doppler study, the velocity is now more than 4 meters per second because you increase the contractility, you increase the flow across the valve, and now the velocity is what it should have been, greater than or equal to 4 meters per second. And the mean gradient is now greater than 30 to 40 millimeters mercury. So, and then when you calculate the valve area using the continuity equation, it's now less than 1. So this is a patient who this patient does have severe aortic stenosis, okay? But you distinguish this patient from this up here, okay, which is crucial because remember, this patient up here, if you replace the valve, they're not going to do well, okay? And then there's another situation that the heart muscle may be so damaged that given dobutamine, you cannot increase contractility and you cannot increase the stroke volume. So these are a special group of patients because they don't have what we call contractile reserve. You're giving them dobutamine and it could not increase the contractility, the absence of contractile reserve. These patients have poor surgical they have high surgical mortality. You take them to surgery, they're not going to do well because, the heart muscle is so damaged. So it's important to look at this group as well. Okay. So again, when the LV systolic dysfunction with reduced volume exists, you have to use the low dose dobutamine protocol. We start at 2.5 or 5 micrograms per kilogram per minute. You're going to increase the infusion. Remember, arrhythmia, patients with severe aortic stenosis, they have increased chance of arrhythmia. So don't just leave them like that. So you really want to distinguish, or you want to separate the pseudo severe aortic stenosis from the patients who have severe, really severe aortic stenosis. And when you give the dobutamine, you want to look at your stroke volume. You want to see an increase in the stroke volume by more than 20% above the baseline. For the patients with true, you want to see the velocity across the aortic valve greater than or equal to 4 meters per second, or the mean gradient greater than or equal to 40. So And then if the valve area does not exceed 1 centimeter squared, then you know that these patients have true severe aortic stenosis. Okay, you, when you look at the heart rate, you don't want to get the heart rate more than 10 to 20 beats above the baseline, or you don't want it to exceed 100. Okay, so those are, those are the condition that you want to, or those are the stop criteria for the abutment. Okay, so what you're going to do is at each dose, or each stage of the abutment. So you remember every 3 to 5 minutes you're going to increase. So every 3 to 5 minutes you're going to get your LVOT velocity, and you're going to get the aortic valve velocity and mean gradient. You don't have to, at each stage, you don't have to repeat the LVOT diameter. That's usually a fixed number. But what you have to do, each stage, you have to look at the LVOT velocity, and you have to look at the aortic valve velocity and the mean gradient. Okay. Okay. So again, for low flow, low gradient AS with reduced ejection fraction, uh, if the valve area is less than 1 centimeter squared, remember the definition for low flow, low gradient AS. You have to give dobutamine, or you have to do your dobutamine stress test to separate the two groups, because if the patient does not really have severe aortic stenosis, they don't do well, and you don't want to take them to surgery. Okay. So again, if you give your dobutamine and the valve area increase to more than 1 centimeter squared, because now you're increasing the contractility, the increased pressure and force in the ventricle can now open the valve, and when you do your calculation, it's more than 1 centimeter squared. Patient did not have severe aortic stenosis. Okay, you want to see an increase in the stroke volume by more than 20% to tell you that the patient have a good contractile reserve. Okay, and if the patient really have severe aortic stenosis, then the velocity across the aortic valve should be greater than or equal to 4 meters per second, and the mean gradient should be greater than 30 to 40 millimeters mercury. Okay, all right. So there are some important points in patients with low flow, low gradient AS with reduced ejection fraction. So in all echo labs, I mean, they should have this uh, highlight. Okay, so for low flow, low gradient AS with reduced ejection fraction, okay, for one, you need to write down the definition, what it is. Okay, so valve area less than 1 centimeter squared, the mean aortic transvalvular gradient less than 40, the ejection fraction less than 50, and if you do stroke volume index, less than 35 mLs per meter squared. You give the low dose dobutamine to help distinguish between your pseudo falls severe AS versus true severe AS. And you should know the protocol 2.5 to 5, and you're going to increase every 3 to 5. And what you're trying to do is see if you're going to get an increase in the effective aortic valve area by increasing contractility. If the valve area increases to more than 1 centimeter squared, then it's pseudo. Okay, this is not true. This is pseudo. For patients with real aortic stenosis, you'll get a velocity jet across the aortic valve greater than or equal to 4 meters per second, mean gradient between 30 and 40, and then the valve area will be less than 1 centimeter squared. And as we mentioned before, it's a special group who have no, they have the absence of contractile reserve. They cannot increase the stroke volume uh, more than 20%. So these patients have high surgical mortality. Okay. Now we have patients with low flow, low gradient AS with reduced ejection fraction. You also have patients with low flow, low gradient AS with preserved ejection fraction. So now, this is our patients who, good contractility, and you do the valve area is less than 1 centimeter squared. The peak velocity, 3 meters per second. The mean gradient, 30. And you check your measurements and everything is okay. A lot of these patients are patients who have small LV cavity. So elderly female patients who may have significant hypertension and the LV cavity is small. So because the LV cavity is small, they cannot generate a significant stroke volume and flow across the valve to get significant velocity and gradient. So it can be very frustrating, okay? You have to go over your calculations, make sure everything is okay. Um, Again, so you elderly, usually female with a hypertrophic ventricle, small ventricle. Um, so so you go through your assessment. So what you're going to look for in these patients, is it a measurement error? So you always, did I do something, or the technician did something? So you're going to look at the LVOT valve area. You're going to recheck that. Okay, the patient have severe hypertension during the examination. Remember, if the blood pressure is very high, it's going to prevent blood from flowing across the aortic valve. So it's going to reduce the velocity, it's going to reduce the gradient. Okay, so you're going to check that. So these are the things that uh, you're going to look for. So the definition for low flow, low gradient is we preserve ejection fraction now. If the valve area is less than 1 centimeter squared, the peak gradient across the aortic valve is less than 4 meters per second. The mean gradient is less than 40, and the ejection fraction is greater than or equal to 50%. So this is the definition for low flow, low gradient AS with preserved ejection fraction. Again, so what you're going to do, did I make any errors or the technician made some errors? So measurement errors, you'll have to go over it. Did I underestimate the LVOT area? And commonly you give the diameter, you make the diameter too small. And so when you do your continuity equation measurement, the value is less than 1 centimeter squared. The patient have severe hypertension during the exam. And so, and then what you need to look, is it a small patient with a significant hypertrophic ventricle with a small LV cavity. So this is how they want you to approach these patients. So they talk about a new classification of aortic stenosis by gradient flow and ejection fraction. So when a patient comes into the lab and you do your studies, then if the valve area is less than 1 centimeter squared, then this is, by definition, this is severe. So the next thing you look at is the velocity. Is the velocity less than 4 meters per second? Is the mean gradient less than 40? So if the patient have a valve area less than 1 centimeter and the ejection fraction is normal, okay, then we talk about, all right, first let's this is when you look at all those numbers, if the velocity, sorry, if the valve area is less than 1 centimeter squared, then by definition that's severe. But when you look at the gradient, the velocity, if it's more than, if it's greater than or equal to 4 meters per second, mean gradient greater than or equal to 40, then this is a high gradient situation, okay? Versus a low gradient if the mean gradient is less than 40. So patient comes, valve area is less than 1 centimeter squared, you look at the velocity and the gradient. If their velocity is greater than or equal to 4, mean gradient, then this is a high gradient situation. If the mean gradient is less than 40, it's a low gradient situation, okay? Then the next thing you can look at is the flow across the valve, the stroke volume index. If the stroke volume index is greater than or equal to 35, then this is a high, this is a normal flow. It's a normal flow. A low flow is the stroke volume index is less than 35. And then you need to look at the ejection fraction. For preserved ejection fraction, EF is greater than or equal to 50%. For reduced ejection fraction, less than 50%. So this is how you should start approaching these patients with severe stenosis. Okay, so these are just some additional stuff, because the patient comes to the lab and you do all your calculation, you need additional stuff to help you to say, yeah, this is definitely severe aortic stenosis. And of course, some of those is physical examination. Yeah, you have to examine the patient. Does the patient have symptoms? Is it a older patient? So, if the patient has symptoms, older patient, then it may be severe aortic stenosis. A very important point is what we call a calcium score by multi-slice CT scan. And if you have a lot of calcification, it's more than likely severe aortic stenosis. And these are some cutoff figures. But the essential thing is there a lot of calcification? Yes. Okay. So again, when your patient comes in and you get a number that suggests severe aortic stenosis, what is this a high gradient situation or is it a low gradient situation? If it's a high gradient situation, then all bets are off. That is a regular patient. If your velocity is more than greater than or equal to 4 meters per second, mean gradient is greater than or equal to 40, then this is a regular patient with severe aortic stenosis. If the patient have a low gradient situation though, then you have to look at the flow across the valve, the stroke volume index. You have to look at the ejection fraction. Is the ejection fraction normal? Is the ejection fraction reduced? Remember, when we have patients with reduced ejection fraction, we have to do something more. So if the ejection fraction is reduced, we do a Abutment stress test to distinguish those who have true aortic stenosis from those who have pseudo aortic stenosis. All right, so let us stop here and